Good evening friends and welcome back to the Thursday evening PG teaching session brought to you from San Hospital, Mumbai. We thank the authorities at San Hospital for allowing us to conduct these classes here, and we also thank Aristo Pharma for their educational grant which helps us to live webcast these classes. Today we have two cases, and the first case is being presented by Dr. Mamta from San Hospital. So we'll start with that case.
Good evening everyone, I am Dr. Mamta and I will be presenting for today's Thursday clinic. So my patient is 6-year-old girl, second by birth order, born of non-consanguineous marriage, Hindu by religion, hailing from UP, informant being mother, who is reliable, brought with complaints of fever 10 days back for 2 days, swelling over the body since last 8 days and passing frothy urine since 4 days. Patient was apparently already 10 days back when she had fever, low grade, undocumented, and child was active in interfebrile period. Fever was relieved after 2 days with some medication. 8 days back, mother noticed swelling around eyes, more in the morning, which gradually used to decrease over the day, but never resolved completely. 2 days later, mother also noticed swelling gradually progressing to lower limbs and abdomen. 4 days back, mother noticed patient is passing soap water like urine. Also, on inquiry, associated with decreased frequency of the urination. Initially, patient used to pass urine 6 to 8 times a day, but now passing 2 to 3 times a day. There is no history of chest pain, easy fatigability, palpitation or forehead sweating. No history of jaundice, hematemesis, melena. No history of decreased appetite, weight loss or hair changes. No history of crying during micturition. No history of chronic drug intake, no history of rash or joint pain, no history of Cox contact, there is no history of abdo pain, loose stool vomiting, no history of headache, visual disturbances, there is no history of breathlessness. Past history of similar complaint 6 months back, where patient was treated at the native place and was told to have some problem in kidney and was treated with some medication which was asked to take with milk, and swelling was resolved, so patient didn't continue the medications. There is also history of recurrent cough associated with increased work of breathing present, for which patient is taking nebulization on OPD basis but never admitted. 4 to 5 episodes per year, more during the winter period, but patient never required admissions. ANC, it was registered pregnancy and uneventful. Birth, full term, normal vaginal delivery. It was home delivery by Dai, cried immediately after birth, birth weight of approximately 2.5 kg, birth vaccine received, and exclusively breastfed till 5 months of age. Postnatal period was uneventful. Child is immunized as immunized till date as per the National Immunization Schedule. Dietary history, child consumes mixed diet, calorie required are 1350 kilocalorie per day, and intake is 1000 kilocalorie per day. Protein requirement is 25.5 gram per day and intake is 22 gram per day. There is a deficit of 350 kilocalorie per day and 3.5 gram proteins per day. Developmentally, all milestones achieved at appropriate age. Now goes to school, senior KG, and good scholastic performance. There is no significant family history and family belongs to lower socioeconomic state.
Okay, so we'll start with the beginning. So 2 days of low grade undocumented fever, and after that on the 3rd day the mother noticed swelling around the eyes in the morning, right? So at that time what would you have thought? What would be your thoughts have been at that time when you were the doctor on the 3rd day and she just came with swelling around the eyes in the morning?
How was the general condition of the child? Whether the child appeared sick or was he fairly normal?
Question is valid, but do you expect this child to be sick? In what situation will a 2-day low-grade fever child with swelling of eyes be sick? No. So you almost can't think of anything else. There can be argument-wise one condition, but the situation will be slightly different. But let's see. So what will you do?
Looks like a renal origin of.
Why renal origin? Straight.
In the around the
What is the
eyes.
commonest cause of swelling around the eye? Local cause. So how will you rule out local cause?
Unilateral.
Signs of
Very good.
inflammation.
Unilateral or bilateral. Okay. So that's the first thing you will focus on. Now suppose it is bilateral, then local cause is almost ruled out. Of course, there are other things for local cause like redness, pain, discharge, whatever. Okay. Now bilateral, but still commoner than nephrotic, what will you think of? I'm just wanting you to keep your mind broad. Then we'll come to nephrotic.
Inadequate or excessive sleep.
Very good. Inadequate or excessive sleep can make your eyes look puffy. Then allergy, very good. So now allergy you will think of. Now how will you differentiate that? Is this allergy or this is not allergy?
There be history of any food or drug allergy which can be documented.
So,
Watery
one
eyes.
sec. History of what food?
History of matlab, in case if we had any allergy, previous episodes of allergic reactions.
Okay, so previous episodes of allergy, but suppose there are no previous episodes of allergy.
We have to check
First
for the
time.
local signs like itchy eyes.
Very good. So itching. Okay, then
Redness, chemosis.
redness. Okay, then
Watering, some associated watering from the eyes as well as nose sometimes.
stop. So when do you get watering and from the eyes and nose? In what kind of allergy? This I thought we were talking of things like food allergy or drug allergy or something like
Dust
that.
allergies, pollen,
Correct.
dust.
So that is the other manifestation of allergy. But what else will tell you whether in this child it's allergy or no? On the third day when he came with fever and morning cyst swelling.
Lip swelling.
Progression. Like if it's allergic, it will decrease in 2 or 3 days. It will subside.
Okay, so progression over time will tell you whether it's allergic. What else?
Sudden onset. Sudden onset.
Very good. Sudden onset is something which you have to look for. Now if they tell in the early morning, then you don't know whether it happened at 5 a.m. or at last night 10 a.m. that you don't know. Okay. But what drug can be consumed for that low grade fever which can cause allergy?
Ibuprofen can cause allergy.
Augmentin, ibuprofen.
Okay. So any antibiotic and ibuprofen may be. Okay. Anything else? So then if you just keep in mind on that morning that okay, this may be renal, what would you do?
Check for albumin. Check for urine albumin.
With that slight puffiness only you will check, or you will wait for the swelling to increase and then check? Suppose you are too early and you miss the nephrotic.
Edema. We'll look for the progression of the edema. and inquire about history of decreased urine output. How is urine output?
Do all nephrotics come with decreased urine output? Why do they get decreased urine output?
Because of the decreased ineffective plasma volume.
So that stage takes a little time. I mean, once the disease is a little progressed, you have all generalized swelling, then maybe you will get that stage, right? So that's not very important. Yeah. So I just I tricked you into saying that it's too early, you will miss it. Even if it is nephrotic and you do it even at that mild puffy stage, you're bound to get nephrotic range proteinuria, and it's not too early. It's only already after that proteinuria happens that you will start getting edema. But if you choose to wait and your patient is for follow-up well connected for follow-up, you may explain to them that okay, let's wait for a day, let's see what happens tomorrow. There's no urgency.
I think let's look at systematically. If you were there only on the first 2 days, there was only fever, you would have said, I don't know what's the cause, but there is no clue. The child is not very sick maybe. So you would have said, wait and watch, it could be a viral infection. We would have left at that. Okay. Thereafter, next morning, the mother noticed swelling around the eyes. So I start wondering, why is this complication occurring in a child who starts with fever? When you start with fever for 2 days, you almost never expect a swelling to come up. You may expect cough, cold, breathlessness, whatever. Something funny is happening. Okay. So why should that happen at all? And therefore I start looking at whether it is a complication of that infection which caused fever. Can you think of something that comes with a 2 days of viral fever, and as a complication, the patient develops swelling? You get my point? Normally, 2 days of fever, what questions would you have asked? Or do you have any severe headache, any body ache, okay, any cold cough, any vomiting, any nausea, any diarrhea, whatever? You would have never asked about the swelling. What does it mean? You rarely expect an occurrence of swelling preceded by fever. Okay, but this child did that. Now, I am asking you a question. Have you seen any time 2 days of fever and then as a complication of that infection? We have already said that no common infection after 2 days of fever develops swelling. Okay.
Okay, dengue.
Dengue.
Excellent. Dengue fever. Now tell me why this is not dengue. Don't go further. Okay, by next evening, whole body, etc. That's all right. Even dengue can have a lot of swelling. So why not dengue? Excellent. Okay, good thought. Give a thought. Doesn't matter. Doesn't matter. Give a thought.
The fever will be typically high grade and associated with headache and body ache, and she doesn't have any of the associations.
Okay, so one reason is the prior illness doesn't look like dengue. What else?
In dengue, febrile phase may last for 4 to 5 days.
And then
may critical phase. We may see the swelling in critical phase.
Okay.
So the point is, you are right that generally you would have had a high fever. Should dengue not cause a low fever? Can any infection which is supposed to cause high fever generally, can it not cause a low fever? And the answer is, if you are partially immune, you have had some dengue earlier, okay, you are partially immune, so this time you get not a classical standard pattern. You are right. I'm just trying to quiz you to say that how the medicine becomes complex and you need to give a thought to everything. Now tell me, would a second episode of dengue is likely to cause complication or a first? Second, you got the thing. This must be dengue. Dengue coming with partial immunity, low fever, risk of complication, you are now that. Now tell me why not dengue still? And there is oliguria already coming, but that will come later, okay.
The onset swelling initially will not come around the eyes.
I'm talking about the first morning that the child visited you with swelling. Okay. See, the fun of medicine is to take the whole sequence and start understanding how early you can diagnose a condition. Okay. After all, at the end of the whole story, everybody knows what it is.
So go back to all your general dengues, your 100 dengues that you see. The one who complicates, what happens to those people? Just.
So when
Usually urine output falls, as in third spacing.
Before all this happened, just before all this happened.
Abdominal pain and hepatomegaly, we can.
They vitally deteriorate. This child seems to be vitally stable.
okay.
Okay, all that you are saying is after the complication starts. What happened just before that?
Fever disappears.
Fever disappears and then comes back mild or high? High fever, no? It comes back as a high fever. So immune mediated fever comes back as a complication as high fever.
See, every time a new symptom comes, you start realizing origin, duration, progress. You should have asked, how was the child when suddenly edema came up? Was he sick? No, sir, he was fine. Dengue is ruled out. Capillary leak is going into shock. So the point is that you imagine if you are there. This is the way to learn medicine. After all, patients rarely come. She came to you only when the whole body was swollen. Even a quack knows. Okay. But we imagine, why did the first 2 days, whoever doctor saw, why did he not think what it could go for? And therefore we know it's not dengue. Okay. Anything else can happen. So dengue is an immune complication, right? Could any other immune complications cause swelling around the eyes? Immune complications. Is acute glomerulonephritis, streptococcal an immune complication? Could it occur after any other infections? Answer is yes. Though post-streptococcal AGN is a typical syndrome where the outcome is excellent. But any infection could do that, and the outcome may not be that benign. Could it be that? So now I am talking about an immune-mediated glomerulonephritis. Yet the swelling is only around the eyes. Okay, so you would have asked for oliguria. Yes, this child had oliguria. Oh, I got the diagnosis. Hematuria may not be obvious. Microscopic, oliguria, edema, prior. What's your point against that?
But this child has frothy urine, so this must be pretty high proteinuria.
No, proteinuria is your defense against, you already have decided it's proteinuria. Okay, I'm still on 2 days of fever and next morning swelling. Typical glomerulonephritis, isn't it? So you would have said, are you heading for that? So what is your point against it likely to be glomerulonephritis?
Yeah, see, always go back to whichever AGN you have seen and match the story.
There is a time period between the fever and the onset of the swelling.
So generally there is some interval between the two. Okay. And a typical streptococcal infection, even a week or two. Rheumatic fever, nephritis. Okay. So probably not. And therefore, something that has fever and a complication, but the fever disappears. Okay. For example, a leptospira can start with fever, and while the fever is on and the infection is on, You may get an immune complication, the fever continues, and then you get liver, kidney, whatever. So sometimes the immune complications of infection overlap the primary infection manifestation. But in that case, the person is getting sicker. That's why the important question would have been, how was the child when he developed swelling? And the mother said, oh, he was fine. All complications are ruled out. Okay. Now he got all over. So you knew that this was. Why nephrotic syndrome? Which nephrotic syndrome comes with fever for 2 days? So anything other than nephrotic syndrome. You agree, nephrotic syndrome suddenly arrive. And prior to that there may not be any history at all. Okay.
Low grade and undocumented, so maybe not related to the illness.
So which edema is precipitated by 2 days of fever? I am not saying complications. Complications are ruled out because the patient is not sick. But precipitated by, and what do you mean by precipitated by? He has already a silent disorder. Okay. And 2 silent disorders come like this. One is a protein energy malnutrition and another is a nephrotic syndrome. Silent. So if this child has a PEM, a small 2 days fever is enough to get the subclinical problem into clinical manifestation. And same thing, if this is a nephrotic syndrome, which is triggered by that 2 days of fever, then this child must have had a past history of nephrotic syndrome. Silent disease or a susceptible to that silent disease. Now tell me why this is not PM. Then I will accept your nephrotic syndrome. Okay. Why not PM? Give a thought. Okay. I'm sure you all know it. If you start thinking, you will answer correctly. Take a note of everything that is put upon there and tell me which is strongly against PEM.
Swelling around eyes with sudden onset in morning and which is gradually progressing to all over body. While in PEM there will be slightly chronic history with pedal edema and limb edema rather than periorbital swelling.
Okay. Let me ask you a point blank question. What's the common age of PEM? 6 years?
Less than 5 years.
But can 6 years not develop PM? Then this is that 6-year PM. And therefore the story should start how well he was prior to onset. I am making that point. That is not put up here. So if this was a child who was never normal, whatever abnormalities, then we know that. And now that if it was a PM, he was never normal. And PM at 6 years of age is secondary. Right? So can nephrotic syndrome can cause PM? Secondary to kidney disease.
What is the meaning of secondary PM? What is sir talking about?
Other than nutritional deficiency.
So systemic disease causing failure to grow or undernutrition. So
and therefore the chronic infections, okay, possibly would lead to chronic organ dysfunctions. Now if this child was never sick prior, then he is a apparently normal child, but we already said that fever has triggered a silent problem. Then silent problem was not nutritional, silent problem was a similar susceptibility to develop. And there you get a nephrotic syndrome. Okay, now you know that in an established nephrotic syndrome, who is on treatment well or otherwise, whatever, even a small infection triggers a silent disease or a suppressed disease. And I think this is what must have happened. See, the fun is, only with edema feet in the morning, you could have told the parents, I'm a little worried. If edema worsens all over the body, no, let me know. I'm going to check the urine anyway. you could have predicted a nephrotic syndrome to come up, right?
There's one question from our online viewers. What is the schedule of these classes? So these classes are every Thursday 6 to 8 p.m. And if you are asking about the schedule as in the topics or the cases to be discussed, then we don't know those cases ahead of time, because we don't know which case is going to be admitted in the wards and available for discussion on Thursday. So the point is that we don't discuss very hi-fi stuff here. So even if you don't know the topic that is going to be discussed today, if you attend regularly, this is just going to teach you clinical skills, how to think and how to use the knowledge that you are gathering in day-to-day wards, seeing day-to-day cases in children in your wards. So that's why we don't have a schedule that, okay, today nephrotic and tomorrow, next Thursday, rheumatic heart disease or whatever, right?
I think the fun of medicine is not to know anything and start. Because tomorrow when you sit in your office, you cannot tell the patient, पहले बता दो क्या problem है, मैं पढ़ के आ जाऊँगा. नहीं. Okay. So we are exactly preparing you for that. And what did we discuss? We did not discuss anything that you did not know. We did not discuss any hi-fi science at all. We discussed something which even a beginner should know. So I think the fun is that. And see, nephrotic syndrome, everybody would have said. And now by now you would have known that we must have discussed nephrotic syndrome at Science, even with your batch 3-4 times. But each time we have brought something new for you to absorb. Okay. And I think that gives you a little wider open mind to say, let me think and act. Okay. So I understand. Earlier days, when it was better organized than now, and that is only the cooperation with these people. If I know on Monday which system you are presenting, we used to bring a super specialist of that system here who would talk after we talk to tell us how we could have even done better. Okay, but that is possible only on Monday if he knows that. And then we had always, in Mumbai there are many specialists, and we would always get one. Okay. So I think about that. We stopped doing it because we don't know ourselves. Maybe last minute something happened. And Sion Hospital is a busy place. Okay. I imagine every system can be brought here on every Thursday. Where is the problem? Okay. I was also at a general hospital. Cardiac cases are there, neurology are there, liver is there, everything is there. And if nothing is there, you bring a normal fellow and I will show that everybody will give me a diagnosis, show abnormal findings. So even that is not a bad idea. Let's go further.
Okay, so now just again to strengthen our ideas, we're looking at this negative history. So the first one, no history of chest pain, easy fatigability, palpitations, forehead sweating is for cardiac. I'm asking a different thing now. As sir said, we'll learn newer and newer things. We know that this is not cardiac. Suppose you get a child who has a cardiac history. I want to ask you, which of these symptoms will be first? What will be the order of symptomatology?
Forehead sweating.
So patient will come to the doctor saying, doctor, I've got forehead sweating. Huh? Easy fatigability. Okay. Then suck cycle if it's an infant. Okay. Then palpitations.
Dyspnea on exertion.
Huh? Yeah. So dyspnea on exertion, easy fatigability, suck cycle. Now palpitations. So we're talking of edema, right? So in a child who will ultimately come with edema or swelling. So is palpitation a must in all such stories? Not necessary. Why? We're just discussing to strengthen our thoughts. You may be right, just answer. Why did you say no?
Yeah.
Palpitations generally mean increased output. On the other hand, this total volume is decreased because of the edema, the circulation volume. I'm just thinking, so maybe that may not cause palpitations because the volume
Palpitations
is
is also a subjective finding. Matlab, it's awareness of one's own heartbeat. It's also subjective finding. So some may not come with palpitations also. Some may not feel it is a pathology. Matlab, it is abnormal karke.
So we'll give you clues. So look at it this way. We are talking of edema in the child as a presentation. So left ventricular failure will come as edema, or right ventricular failure will come as right ventricular. That's one part of the story. Now what kind of lesions will give you palpitations, and can those lesions cause right ventricular failure? That's what you have to decide. So what kind of lesions will give you palpitations?
Yeah.
Obstructive left-sided lesions. When cardiac
Okay,
output is low, then compensation will cause tachycardia.
Okay. Anything else? Arrhythmias. So one important reason of palpitations is arrhythmias, right? But arrhythmias will occasionally cause failure, and that too not to give you edema and all that, right? Edema is chronic congestive cardiac failure. Arrhythmias would be sudden if it is SVT or whatever, right? What else gives you palpitation? So does mitral stenosis give you palpitations, or mitral regurg give you palpitation? So it is volume overload conditions which give you palpitation, right? Now volume overload conditions to go in cardiac, right-sided cardiac failure, what will be the story? Okay, VSD, yes. So volume overload conditions have to get into pulmonary vasculature flooding, pulmonary hypertension, then right-sided failure. So it's usually a long story. We are just seeing how each symptom correlates. Now chest pain. So which cardiac conditions come with chest pain? And then we'll see whether they come with edema.
Pericarditis.
Pericarditis. Then
The conditions which cause stress on myocardium, like aortic stenosis, can come with chest pain on.
okay, very good. Why does aortic stenosis cause chest pain?
It has a decreased cardiac output in times of exertion, so decreased coronary perfusion.
Okay. So does aortic regurg also cause chest pain? It can. Okay, because immediately after the ventricle pumps, there is so much runoff that the coronaries are not filled properly, right? So these are the two valvular conditions which can come with chest pain, and then of course pericarditis, right? And forehead sweating is rarely a patient complaint unless it's an infant. Okay? So we're just
Even
getting
I sweat
into
on my forehead. What is this forehead sweating? Who doesn't sweat in this city? So what is forehead sweating? And as if there is no sweating anywhere else? Or forehead sweating, the nature says doctor must look at it. So forehead.
So usually children are clothed, they are wrapped, so that's generally the exposed part, and they are when they are feeding, generally that's when the forehead sweating is there, which is equivalent of exerting for them. So non-exertional forehead sweating is not expected. But
So in other words, the acute onset of forehead sweating as a response of an autonomic nervous system may not mean only cardiac. Okay, even a certain hypoglycemia, yes. So it only means that the problem has acutely come up. That's it.
and the what sir said, autonomic nervous system. So your sweat glands are there everywhere, but these are very sensitive to the autonomic disturbances. So it is the sympathetic stimulation which is showing. whether in hypoglycemia and you get forehead sweating and you faint, right? That kind of a thing.
So I think the best way in negative history should have been no history suggestive of cardiac, liver, etc., etc. Fine. Okay, that's enough for you to know that you have thought of all that. But it's not that negative history should rule out every possible cause. For example, if somebody comes with PO, you can't say that he has no urinary symptoms, no this, no that, no. So in fact, in this child, you should have said that negative history only for acute onset edema. And the liver, the cardiac, nutrition are all not acute onset edema. So which is another acute onset edema? The allergy. And what question you would have asked? Only edema of the thing. Any history of allergy or itching. Okay. Otherwise, no need of putting all this. I understand that you are trying to tell me that all other causes of edema are ruled out. Okay. But that is not the way to put up. You say no history of any other illness. That's enough, right?
Now in the previous episode, he was given some medicines, told kidney problem, he got better and he stopped and nothing happened for 6 months. So kidney problem is ruled out, no? He didn't complete the course. He just took for a few days and still got better. So it must not have been a kidney problem.
Might have been partial remission. Partial remission.
So if it was partial remission, should it have come back immediately after stopping the steroid? So what we are trying to ask you is, what happens to a nephrotic if it is not treated or if it is half treated? What can happen? Does it always have to go on and on and on until it is treated, or what happens? Or in other words, we are also asking you, why are you treating a nephrotic who responds on the 8th or 9th day with proteinuria being absent, and by say 15, 17 days his edema is gone? Why are you treating him for 6 weeks and 8 weeks? If this was good enough to treat him few days, then why we give 6 weeks, 8 weeks, 3 months?
I'll give you another clue. I get urticaria. Okay, all of a sudden, I am very uncomfortable. I phone my doctor. I must be seen immediately. I am rushing to you. By the time I go to him, there is nothing. Did I take any medication? So does allergic disorders or immune-mediated disorders resolve suddenly? The answer is yes. But not everyone will resolve. And why is that? It depends on what type of immune response the host is pushing. And just to revise, which are the 4 types of immune responses that second MBBS? Okay, not far back. Okay, you are a fresher, right? Yes. He presented very well, right? At SRCC 2 weeks ago. I was impressed. And he said he is first year. He presented very well. So I told him that he must come here. And just last session, she presented. She not only presented, she answered every difficult question well. So I said, why don't you come? Okay, I was pleading them for a long time, but I had to plead them several times. I did not know how often, but it worked last time. Good. So give a thought.
Any thoughts? You can collectively come out with.
Which is the type of immune response when I suddenly go down? Sir, I took the tablet and suddenly, okay, swelling came, I started panting.
Type 1, sir.
Anaphylaxis.
Anaphylaxis.
Okay, that's one type of response. Obviously not this.
Which is a Mantoux type of response?
What is the Mantoux type of response?
Delayed hypersensitivity.
Delayed hypersensitivity. That's the other extreme. It comes often after a few weeks. and in between are the antigen-antibody complex related or only antigen related. It depends on which type of response the host is pushing in a particular disease. That's number one. And second is, how competent is the host to push that response? Okay. If I am a weak person immunologically, I may not push much. Okay. And therefore, that's what he's asking. That
So, what sir said absolutely, and spontaneous remission is also known sometimes. And the second part of the question, why we treat long, is to prevent relapses. So it has been studied after long and after so many cases that that kind of a duration minimizes relapses. So that is why we treat for that
earlier,
long.
when we did not know how to treat nephrotic syndrome correctly, one way was to expose this child to an infectious disease. And I have seen that in 60s, where, oh, your child has measles or something, please bring him to my home, my child has nephrotic syndrome. And he would get better. Okay. And the reason was, really, he would contract that infection, and it was thought that when you get infection, your adrenals pour up steroids, but that is small amount, and in return you may get a serious illness. So all that is gone now. But the point is, the body might secrete as a response some small steroids, and it could be disappearing, but will recur because it's only suppression. Okay. But anyway, steroid is a suppressive therapy only, no? So how is it 6 weeks, okay, full, and then maybe less dose for another 4 weeks? Why this? No treatment is like this. Okay, and that's why this patient stopped. He said steroids. No. Somebody else said, no, don't go to those allopaths. They're mad. And they're giving steroids for weeks. Gone wrong. So why do we do this? Rheumatologists use steroids. Many other times in TBM we use steroids. Okay. We don't do that kind of nonsense. 6 weeks. Okay, single dose in the morning, alternate days thereafter. Who decides that? Some bloke somewhere in the world, and we all blindly follow it. Should there not be an evidence?
Chalo, what is the rationale behind this kind of treatment in nephrotic?
Some all nephrologists sat together and said, we'll do it. And we poor people not know much about nephrology, we also started doing it. And therefore this has come out of the epidemiological studies. Okay, and people have tried, like TB, for example. People are trying a shorter course, okay, because too long a course people drop out. So based on all this, therefore this, and the first episode, most important, based on epidemiological observation, that if you treat fully along, there is a good chance of not having relapse. However, the relapses will still come, but less often. And the second time, don't waste time again, 6 weeks, 8 weeks, etc. Now you have failed once, now you just do a short course. That is based on those studies, right?
Okay, now last thing, unrelated, history of recurrent cough with breathing, increased work of breathing, for which patient is taking nebulization OPD basis, 4 to 5 episodes. What do you make out of this history? Is it related? Is it unrelated? May it be partly related?
It must be nephrotic related, because nephrotic is allergic. This is also allergy. Both are immune mediated. Don't you get different immune mediated disorders? Would you agree to that?
Come on, what do you make out of that history? Irrespective of the nephrotic, how will you treat that history, or how will you assess that child for that kind of history?
It is looking like a hyperreactive airway disease.
Okay, so it's looking like a reactive airway disease. What else? Any other observations?
So if as a host you put up one of those 4 types of responses, then you are susceptible to put the same type of response, and the diseases which arise with same type of response, which a similar trigger, like an infection maybe, or a vaccine maybe, would get thing. For example, we present a child who presents with pneumonia, but he's not getting well, and he's not deteriorating also. And then you ask for past history. He had a past history of acute glomerulonephritis a year ago, and 2-3 years ago he had an immune-mediated thrombocytopenic purpura. So we know that he has this kind of a response, and then this comes to be a Wegener's granulomatosis, not the bacterial pneumonia, but similar problems. And that is how possibly asthma or a hyperreactive airway, even if it is immune-mediated, the immune mediation is different than the nephrotic syndrome, so 2 are not connected. Okay. And of course the triggers are also different. That trigger is inhaled some whatever dust mites or whatever that.
So will you treat him for that reactive airway disease with preventive inhalers, or you will not treat him?
He is not needing any admissions for the episodes.
So if someone doesn't need admission, you don't treat him with preventive inhalers. Is that the equation?
We generally look for the nighttime awakenings and the daytime symptoms throughout the weeks, and like for the longer period of time after doing the prolonged follow-up, and then we decide.
So that is not dependent on admissions. So first point I want to make is that not needing admission does not mean he does not need inhalers. Now, ulta any significance? Suppose he has been admitted once, first time, but he doesn't have this long story. Then does he need inhalers? Yes. So even one admission, irrespective of that long story, it is better to give him a plan, right? But the other way around, you don't need to be admitted to decide that you need long term. So you'll ask for all those details. Here it is mentioned that it could be seasonal. It is said that it is in winter. So you will again look into the details whether it's really seasonal or it is there all year around, etc., and then decide on long-term treatment. Right?
He must have got inhaled steroids also, nebulized. Do you think that was one reason why nephrotic was suppressed? After all, it's a steroid. And inhaled steroids also have some absorption. You can't go on fooling them. There could be a side effect.
So the absorption of steroids is very less through the respiratory tract, not enough to produce
So absorption is extremely small, and the dose itself is very small. So that is of no use for any systemic use at all, right?
Okay, fine. So now tell us your provisional diagnosis. How will you summarize this child's story? Anybody? Then we move to examination.
How would you summarize? In summary, use adjectives and make as brief as possible. ABC, accurate, brief and clear. Okay, we'll learn that. To begin with, you can give me the whole essay on that, but keep that in mind, right? And again, anatomy, pathology, etiology and functional. You must tell us in summary, where is the disease? Anatomy, what type of disease? Pathology, what's the cause of disease? Etiology, and what's the status of the organ? Is it failing? Is it fine? That's the summary.
So this is a 6-year-old female child coming up with fever and edema, most probably due to kidney-related causes, as there are no signs of failure or hepatic causes. Probably triggered by the infection which was there as manifested as 2 days fever.
Fine. So acute onset edema triggered by 2 days of fever spreading fast, generalized, in a child who does not look sick, is mostly a nephrotic syndrome. And what are the peculiarities of nephrotic syndrome? Acute onset, generalized edema, no sickness, triggered by some infection. Fine? Good.
So, on examination, so child is patient is there.
Come on, one or two volunteers to come near the patient and
Just put on these
start
lights
talking.
here.
Come, who wants to come?
Some lights are less. I think this side lights are less.
I think you can see mostly everything. Somebody starts talking what you are seeing from that. Okay. And we have already said inspection is observation. So, whatever you see, it should go to your cortex for the analysis of what you are saying. Right? So, start talking.
She has periorbital edema. There is pallor also.
Right. So she is in cardiac failure due to anemia. Spot diagnosis.
So,
It doesn't look
observation start from general observation, how sick the child is. Comfortable.
Comfortable, not sick looking.
So, comfortable, acutely sick or chronically sick? Okay.
Acute.
How do you differentiate chronically sick from acutely sick? Both are uncomfortable.
Growth and nourishment is fairly okay. And she is not tachypneic or dyspneic.
She looks interested in the environment. There is no signs of tachypnea, or she looks comfortable from her face, so she doesn't look acutely sick.
Chronically sick is a compensated state with nutritional deficit. Acutely sick has no compensation. So the degree of sickness, acute, chronic, mild, acute may be malnourished, or if luckily well nourished, yes, then it's not chronic. So degree of that, very comfortable, right? So that's your first, growth. How is the growth? 6-year-old. Guess from outside.
Short stage.
She's looking short. Short for age. Okay.
All right.
Weight.
Weight looks small. So look at this gentleman. Okay. So the stature looks similar. Okay. Yeah.
Weight for height is looking okay, but
Excellent. Weight for height looks all right. Weight for height is all right. There is no nutritional problem. Looks weight is small, maybe height may be a little small, but weight for height is normal. So this child is normal. Okay. In nutrition, in growth, comfort, you knew so much. And then periorbital edema. Is there an abdominal distension?
Probably, yes.
Yeah, हाथ खाली ठेव, हाथ खाली ठेव.
तो हाथ ऐसे साइड में रख दो ऐसे. हाँ, ऐसे रख. हाँ.
Yeah. Maybe we'll look at that on examination, right? Is there a swelling on the feet? Maybe not large, but could be, but we'll have to examine that, right? Fine. no tachypnea. Do you want to expect tachypnea in a nephrotic? Why are we wasting time?
If there is pleural effusion,
Pleural
or
effusion.
third spacing basically.
Okay, so you'll have to note of tachypnea. And if this child has pleural effusion and tachypnea, would there be indrawing also? Intercostal retraction, subcostal? No, no retraction. Pleural effusion. Pneumonia retraction. In pleural effusion, no retraction. Why?
Parenchymal.
There is no parenchymal disease. So no retraction. That's what you are trying to say. Can you expand your answer a little? So let me ask the other way around. Why is there retraction in parenchymal disease?
Decreased oxygen, oxygen levels are affected.
Oxygen reserves are affected, but something more. It takes more effort to open the solidified lung. So that is why retractions in parenchymal disease here. So in your pleural disease, lung is fine. Nothing is wrong with the lung in terms of its easy expansion or whatever. So no retraction.
But if there is a large effusion, would he not be having retraction? Underlying lung is not able to kind of expand.
Fullness of rib spaces.
If there is a large effusion on one side, it would be a intercostal fullness we would be feeling, not retractions most probably.
The question is, if it develops acutely, the other lung is not ready to take over the charge. And then acute one, there could be a significant collapse of the underlying lung. However, the tachypnea is so much that there is no chance of retraction. Acute bronchiolitis don't retract also because there is an emphysema and there is a shallow, fast breathing. Okay, and to that extent, we don't expect any retraction at all. Fine. Now, I want you to also observe and tell me whether she is on treatment. That's why possibly most of the edema has gone. Can you see any evidence of treatment in her?
There is a fullness of cheeks.
Cheeks are a little prominent, all right. Okay. Look at the stature of the family. His cheeks are not. Okay. Her cheeks are a little prominent. Okay. Fine. What else would you examine? So now let's do another trick. One of you come and examine for steroid toxicity in this child. Forget nephrotic syndrome, now we know that. Okay. What will you watch for steroid effect or steroid toxicity, both? Come. You just tell me what are you examining for steroid effect and then steroid toxicity. First the effect, which means and within a week or two, and then bad effects, side effects. Hold it close.
For effect-wise, we look for the response at how the child was at presentation, and generally the edema is the first part to resolve after we treat the nephrotic. So, how we compare with how the child was and how the child is to see the effect. If the child is on long-term treatment, there will be some Cushing-Goid phase.
What else is visible as an effect of steroid administration?
Happy-go-lucky child.
Very good. So happy, extra happy. So euphoria. Okay.
So what happens in first week? The swelling disappears around the eyes, but starts showing over the cheeks. Okay. By the time a week is over, second week comes, he is euphoric. Okay. So that is where. What happens thereafter? At the end of 4 weeks, what is something that you must look for? Hypertension. Okay. By 4th week, hypertension has come, and something else is likely to come by that time. In between, you have, of course, a risk of infection maybe. Okay. Abdominal distension starts coming up because the liver starts enlarging. Okay. But it's not a major issue. There may be ascites as well, which takes time to disappear, so we will not pick up that. But at the end of 4 weeks, you must check blood pressure. Of course, even earlier you must check, but thereafter you must check every alternate days or every day, and one more examination at that time, because we want to finish 6.
Sorry? Calcium deficiency.
Hold the mic close.
How will you check for calcium deficiency?
Bone mineral density.
No, bone density we don't do so early. Fundus is
Eyes. What do you do?
Cataract.
Glaucoma and the complications because the raised pressure in the...
So what kind of cataract?
Posterior.
Posterior subcapsular. So
Posterior subcapsular cataract, which is not seen simply many times, and therefore you must have an ophthalmology reference. Because you are already seeing 4 weeks of effect and side effects. The next side effect would be that. Okay. And what else would you monitor as a routine? Would you monitor height? Sugar? Yes, maybe. Okay. But a person who is likely to be pre-diabetic will get into little blood sugar. Yes. But the height must be measured. Because long-term steroids would have possibly some suppression of height. So that is what we should do. Now, one quick, tell us whether there is an ascites. She can lie down here.
इधर आ जा बेटा, इधर आओ.
इधर ले जाएंगे बेटा.
ऊपर लेके आओ उसको इधर से, ये बाजू से
पेट
ले.
देखना है, हाँ, पेट देखना है. सर उस तरफ करो. हाँ,
Sir उस तरफ.
Doesn't matter. Let him come from here.
Sir,
Examine
he
from here.
won't
Doesn't
see the
matter.
camera.
Okay, yeah.
अब उधर जा.
Go on that side. सर ये बाजू करो. सर उस तरफ करो. पैर इस तरफ.
कुछ नहीं कर रहे उसको बोल. उठा. अरे. Make friends with her. She's little anxious.
सिर्फ पेट देखना है बेटा, कुछ नहीं करते हो सारे. सिर्फ पेट देखना है 2 मिनट. हाँ, दर्द नहीं है ना. हाँ, वेरी गुड. फर्स्ट इंस्पेक्शन.
On inspection, the abdomen looks distended with a smiling umbilicus.
What kind of
There is
distension?
generalized distension.
Central, flanks,
Flanks are
upper
looking,
abdomen.
Flanks are looking full on the both the sides.
Flanks are full.
Yes.
What do you think?
Central abdomen distension.
Okay. So, 2 of you come near and say whether flanks are full. Last time also we had a problem. Okay. Come near and say whether flanks are full. So, not so easy, huh? Flanks full or not full. Okay. They can fool us. Do you think, no, just inspection. Last time Rajesh showed by action what is flank full and what is not flank full. Would somebody remember? Rajesh, you will have to show it again.
So see, basically we always, now this is the abdomen. So flank is this area. So flank full means it is, the curve is like this. So in that whole distension, it is laterally more distended. That is flank full. So here lot of distension, here lot of distension. And when it is like this dome shape where the top is more distended, more vertically, then it is not flank full. Now here it is lateral, but yet the flank is not prominent. So lateral tells you that there must have been fluid, but maybe she is already on treatment and it's a little less. So it's not like a frank flank fullness, right?
So it is, if you see this, there is suddenly little convexity coming. That is a flank fullness. What is the umbilicus-like, stretched ears. Is it situated at the right place?
More at the caudal end.
It has been pushed down. Look at this and look at this. Why is it pushed down? So when does the umbilicus gets pushed down in an abdominal distension? When there is something occupying in the upper abdomen. Okay. Now you palpate and tell us whether there is something occupying there. We said earlier on few occasions when we are discussing nephrotic that that's a tough case to get in an examination. Because there is nothing much the examiner is going to ask you to demonstrate, but we'll ask you something funny to demonstrate. And we'll ask you multiple theoretical questions. It's much better there are too many findings than you are busy only looking at findings. Yes? Otherwise, we are looking at umbilicus, we are looking at this, that. Why? Because there is nothing more to look at. Right?
Sir, on palpation, the liver is palpable around 3 centimeter below the subcostal region.
Is it enough to say 3 centimeters?
We need to see
Then
the liver span also.
What else you want to examine?
Firmness of the liver along with the liver span.
Span. Examine the span. So now we have gone wrong in our analysis. This child has got a liver disease. Yeah. Okay, liver disease with edema. Yeah, nephrotics don't have enlarged liver. Let's see the span. Okay, but see, that umbilicus told us there is something up there. Okay, and now he says 3 centimeters. Okay, so
Span is looking around 6 to 7 centimeters.
6 to 7 centimeters, borderline. Okay, is the liver soft or firm?
Looking firm in consistency.
Firm. Oh. Firm liver, borderline enlargement, chronic liver disease. What more do you want? Nephrotics don't have hepatomegaly.
If we are thinking it as a liver disease with firm liver, there should be some complaints like jaundice, a deranged coagulation profile, something like that. But there are no such complaints.
Chronic liver disease has no jaundice unless there is a liver cell failure occurring. Okay. So this is a compensated cirrhosis. Portal hypertension. Okay. I am going to ask him to examine spleen also. But if he says it's not palpable, I am going to say there is a lot of fluid, so he cannot palpate it. For me, it is still abnormal liver. Okay. Is there a spleen also?
Spleen was
this is not there. Possibly because of ascites, you are not able to see it. And spleen has to enlarge 3 times. Okay, it must have enlarged 2 times already. So why not a liver disease? And in an exam, typically, it's a partially treated child is put to you. And many of them will have a hepatomegaly. We said steroid. Okay. Now tell me, why not a liver disease?
There are no signs of growth failure.
Acute liver disease doesn't come with swelling. It's a chronic liver disease. And chronic liver disease, the child is not comfortable, grown well, so totally out. Then what is the cause of this liver? Okay. Now I'll give you another one. Butt-cherry, ascites and liver, hepatic vein obstruction, butt-cherry. Butt-cherry you get ascites, butt-cherry you get liver. Fine. This is butt-cherry. Now tell me, why not butt-cherry?
Occlusion of vein will cause prominent vessels over the abdomen.
So Occlusion of the vein can be inside, so abdominal vein need not be prominent. If it's there, it helps you. Some stronger reason.
Any predisposing conditions. for that?
Periorbital puffiness would not be present.
So now these are the questions in an examination. Okay, and you're all prepared now. Let him ask any on nephrotic syndrome, but the fellow doesn't ask at all. Then you come out and say, what kind of examiner doesn't ask anything related to a disease? So you got that, right? Okay, I think she can go away. But le jao, huh? Thank you. Le jao.
So on examination, child is non. Child is non-sick looking, well built, sitting comfortably, pulse rate of 100 per minute, regular in rhythm, good volume, no radial or radiofemoral delay, and peripheral pulses are well felt, respiratory rate of 24 per minute, abdominothoracic and there is no distress, blood pressure is 90 by 56 millimeter of mercury, which is 5th to 50th centiles, and saturation on room air is 100%.
100 pulse rate is a bit fast, right? So must be an occult infection. After all, steroid therapy, okay. We must look for peritonitis, okay, UTI. I must investigate further. What's your comment on that?
Pulse rate 100.
To suspect it to be any peritonitis or any other infection, there is no fever right now. And the most probable cause might be the distance and is pushing the diaphragm upward, and eventually child needs more effort to breathe in.
No. Distension pushing. Okay, so one is, was she anxious on examination? Second?
She is in hypovolemic state. So
She is in hypovolemic state. Okay. Better, more logical reasons.
There was oliguria in the history.
The peripheral pulses are well felt, so this is not secondary to low volume.
But there was oliguria, right? So could oliguria give you a mild race, mild tachycardia?
That's what sir is asking. Is it infection?
Why oliguria in nephrotic? I think oliguria is not a symptom of nephrotic. But you said oliguria.
yes.
Yeah. So what does oliguria mean? So it could be dehydration. Whatever the cause, we'll discuss why dehydration in Mumbai some years ago when there was water everywhere, roads were full of water, but the taps did not have water. So here water everywhere, but still not going through the kidneys. Kidneys are hypoperfused. So could this child be dehydrated? So now my next question is, how do you pick up dehydration in a child who has an edema? And one thing I told you, mild tachycardia, first degree dehydration, oliguria and mild tachycardia. This child has got first degree dehydration. How will you pick up?
Mucous membranes. We see mucous membranes.
And therefore look at other things. In other words, you can look at extracellular findings and intracellular findings. Fine. This is just 100 is not.
This child was
normal
pale also, no? You all said on examination pallor. So all that will contribute to.
Anthro-wise, weight is 17 kg, which is between -1 to median standard deviation. Height is 110 centimeter, which is between -1 to M standard deviation. BMI is 14, -2 to -1 standard deviation, and child is normal by anthro. Head to toe examination, head is normal in size and shape. Periorbital puffiness is present. Ear, nose, throat examination is within normal limit. No facial dysmorphism. Abdominal distension is present. Pitting edema present over the feet till ankle. No genital edema. There is no pallor, clubbing, cyanosis, icterus, lymphadenopathy. Systemic examination, per abdo examination. On inspection, abdomen is distended more in the lower part. Umbilicus is shifted downward and stretched. Flanks are full. No scar, sinuses, visible veins over the abdominal, and hernial orifices are clear. External genitals, no genital edema. On palpation, superficial palpation, there is no tenderness, normal temperature, no guarding rigidity. On deep palpation, liver and spleen were not palpable. Both kidneys are palatable. On percussion, shifting dullness is present, and auscultation, bowel sounds are present. Rest of the systemic examination is within normal limit. So the impression is 5-year, 9-month-old girl presented with fever and anasarca with history of decreased urine output, probably of renal etiology, with ascites, with diet deficit in calories and protein with normal bianthro, immunized till date in a case of inadequately treated nephrotic syndrome.
Both kidneys palatable. Okay.
No, not palpable, you said.
I'm sure you have never said this any time. What does that
palpable,
mean?
Sir.
Even if you thought they were palatable in an exam, better not to say that, and the examiner will not ask you whether they are palatable. But having said it, yes. So are normal kidneys palatable or only abnormal?
Child has gone in the ward, huh? Gone in the wards? Yeah, come on, what is ballotability? We have discussed this.
Enlarged kidneys will be ballotable, not the normal one.
Okay. And what do you mean when you say kidneys are ballotable?
It means we can feel both upper and lower surface of the kidney, which is movable on bimanual examination.
What do you mean upper and lower is anterior and posterior?
Yeah, anterior and posterior surfaces. And we can also examine, it can be ballotable in normal kidneys also.
Normal kidneys can be ballotable.
Yeah.
So ballotability is something which is very difficult to demonstrate, and basically what you mean is that you put one hand under the patient in the lumbar region, and then you are palpating in the abdomen, and then you push your hand niche wala up, thinking that the kidney will move a little on its pedicle, and then it will touch your upper wala hand. That is ballotability. That is possible only when the kidney is enlarged and hydronephrotic. A normal kidney will not be able to do that, right? And it doesn't move like 1 inch or something. It is just a wee bit of movement which you feel, which you call as ballotable.
Just 1 millimeters of movement. Does the brain move in our skull? Or it's tightly fit? Brain also can move. It's not tightly fit, and only if it's a small child, you need to shake him, and that could cause injury. So brain also can move a little, millimeter, nothing more, but that could abut against the bone and cause that.
That is what we call as concussion, no? When just that shaking movement happens, right?
So possibly avoid ballotable. Okay, I have never been able to understand ballotable at all. Okay, and just because we said that's the method of examination of ballotable, would a liver also be examined the similar way, with one hand, one palm posteriorly and one palm anteriorly? And the answer is yes, if it is a pulsatile liver. Pulsatile liver, you should feel pulsation. And when do you get to pulsatile liver? We are just asking you because now you have gone up to the middle level. Okay, having said ballotable. So if you wanted questions on ballotable, you say that sir, kidneys are ballotable. Then the fellow is said, I have never seen in my 50 years, but she has seen. Let me ask her more questions. And you are all ready.
Aortic regurgitation, pulsatile liver.
Regurgitant lesions, tricuspid regurgitant lesions may have a... who has seen that? Somebody who invented is the only one who has seen it. Most of us have not even known, but yes. So, okay, all right.
Before we just go ahead, Dr. Anjali, one of our online teachers, pointed out proximal myopathy as another steroid effect, right? So they get a little, so not hypocalcemia, but proximal myopathy.
Absolutely, yes.
Yeah, so if you tell them to sit and get up, they'll have a difficulty in getting up from the squatting position.
Shall we go for the second case now? Yes. Okay.
Investigation.
Summarize.
Yeah, tell us just positive quickly. Don't read everything. What is the prominent ones you tell us?
Prominent when CBC is hemoglobin is 11.9. In total, RFTs are normal. Electrolytes are also normal. Total protein 4.2 and albumin is 1.9. Urine RM protein were 3 plus. Baki rest of these normal. Urine albumin is 4 plus. UPCR is 19.8. Coxer cup is negative. Child is started on prednisone since last 3 days and edema is subsiding now.
Okay, fine. Thank you.
Thank you. HIV.
HIV, hepatitis B, and HCV.
How poor I am.
Thank you.
Okay, thank you. And we move on to the next case, which is by Dr. Shrikant. Okay, so we'll do that.
Short case presentation. 10-year-old female child, second by birth order, born out of third-degree consanguineous marriage, resident of Mumbai, hailing from Bihar, Muslim by religion, Begum by community. Bought by mother with complaints of abdo pain since 3 months, loose stools since 1 month, fever since 2 days.
I think we'll wait here only and let's ask them the final diagnosis. Then let's see whether we can imagine what must be happening. It doesn't matter. Okay. So who will start analyzing this? Like earlier we did. First 2 months only abdominal pain. Thereafter comes loose stools and last 2 days there is fever. So I want you to analyze first 2 months of this child, only one symptom, abdominal pain. Ask him all questions. Then he may have put it up in the subsequent slide, but who will ask him all questions? Come, somebody wants to try? Ask him all questions and tell me what kind of abdominal pain is this child has. Okay, we'll do another kind of exercise. Okay, come on. So what question do you want to ask? Go on firing questions one by one, like you take a history. Abdominal pain for 2 months.
How is the child otherwise active or sick?
Child is not sick. Child is
abdominal pain is constantly daily or is it episodic pain?
It is actually constant pain which is not relieved by defecation or something like that. No
Okay,
relieving
one
factors.
sec, one sec. So we always ask so many questions, but again try to group them. What is the first aim?
Was it a sick
Anatomy.
child?
So for finding out the anatomy, what questions will you ask?
Which area?
Location.
Where is the
Where
pain?
is the
First start with that.
First anatomy question, then pathology question, then etiology question.
Where is the pain?
Pain is actually in periumbilical in nature.
Okay,
And-
periumbilical. So anatomy is what? What structures are there in periumbilical?
Peritoneum, irritation
Peritoneum,
or small intestine.
small intestine,
And one more.
lymph nodes.
Lymph nodes.
Okay. Now, to further decide the anatomy, you have to also decide whether this is somatic pain or visceral pain. So how do you ask that?
Is it at the same place or is it radiating to other place also?
It's at the same place. It's not radiating.
What else?
Whether he can pinpoint the exact location of the pain or is it diffuse?
Yes, sir. She can actually pinpoint to umbilicus.
Okay. So how do you differentiate between somatic and visceral? One is you said pinpoint. So pinpoint, a better word is to whether it is well localized or diffuse. See, the problem is with children, umbilicus is the easy landmark that they find on the abdominal wall. So even for a pain which is diffuse around the umbilicus, they will pinpoint to the umbilicus. That doesn't mean that it is a pain specifically localized to the umbilicus, right?
And severity. Okay. A localized severe pain versus a generalized not so severe pain. So you get somatic versus visceral. So you at least get the anatomy all right. Then pathology. Would pain be always inflammatory? Or you know non-inflammatory pains? For example, I have a migraine. Is there a inflammation? Then what kind of pain is that?
Stretch pain.
Stretch what?
The vasodilation of
Vasodilation.
So vascular pain. So pain may be mostly inflammatory, sometimes vascular, like myocardial infarct, neurogenic.
Sir, he said obstructive. So by that, what do you mean? When you are talking of intestinal obstruction, why is there pain?
the stretch of.
So that's a mechanical
Mechanical, right? Stretching is mechanical. When liver is enlarged, it's stretching the capsule. So stretch or mechanical, vascular, neurogenic, referred. Okay. I'm complaining of a knee, but it's coming from the hip. Referred. Myocardial infarct, shoulder or jaw, neck, referred, and psychogenic. So now tell me, what pathology must be this? We guess all that. Okay. There is no fever, obviously. So one part of inflammation is gone. Pain, yes. So could this pain be inflammatory or vasogenic, neurogenic, referred, mechanical? What it could be?
It may be a referred pain also, sir. In appendicitis, actually, pain comes first at umbilicus and then it comes at.
If it is diffused, then it's unlikely in a vasculature nor in the nerve. Okay, what is the nerve pain here? It's a nerve going across. So sometimes the typical herpes zoster may come with an abdominal pain, but the pain is in the direction of the dermatome. So there's not neurogenic, there's not vasogenic, okay, there's not mechanical, it's not happened suddenly, okay, it's not psychogenic, it's not referred, must be inflammatory. Okay, you got the pathology? Inflammatory. First diffuse, not so severe, visceral. Visceral, mostly intestine, peritoneum is all over. Lymph node often gets pain only when the lymph nodes are large. Small lymph nodes don't cause pain. So large. So there is often, much before pain, an abdominal lump. So this is intestine. It is inflammation. Acute or chronic? Chronic. Okay. Now ask questions to define chronic inflammation. Any question to ask for chronic inflammation?
Any weight loss?
There is no documented weight loss, sir, but there is adequate weight gain.
Appetite, they want to know.
Appetite is good.
Okay.
So chronic
Fever,
inflammation.
low grade fever.
Low grade fever since 2 days.
Only 2 days.
Only 2 days.
Okay.
So chronic inflammation has some systemic symptoms. Okay, I'm not doing well, I don't have much of appetite, I've lost some weight. We could have asked all that. If it is there, we know it. If it is not there, it could be mild, localized chronic inflammation. Like if I've got a chronic TB lymphadenitis, I may not lose weight, appetite, etc. I can still go about. We are just looking at all that. Could it be psychogenic? 10-year-old. We said mostly inflammatory. Okay. Periumbilical pain is often psychogenic.
Fever can't be
Was the pain occurring every day or any nighttime awakening?
Fever can't be explained if it is
Okay.
Fever can't be explained if it is a psychogenic pain.
But fever just come 2 days back, no? 3 months of psychogenic pain and 2 days of viral fever.
So what question do you ask for psychogenic?
Any pattern, like when it is a particular time or when the child has to go to school, some sort of environmental situation.
Psychogenic symptoms are called symptoms of convenience. When I want to eat, I have no pain. When I want to play, I have no pain. When I want to watch TV, no problem. When I want to go to school, there is pain. That's psychogenic. Just to brush all that, okay. But we would have asked all that, okay. And if that would have said, no, he gets any time. Oh, he woke up in the middle of the night with pain. It's definitely not psychogenic. Then it's chronic inflammatory. Chronic inflammatory with intestinal. So you got chronic intestinal inflammation. Okay. Then why not diarrhea or constipation? Would constipation be also a cause of chronic intestinal? Yes. And therefore we would have to ask a little more detail. Okay, is there any change in the bowel pattern? Okay. For example, I used to pass every day, but now I pass to every 2-3 days. Okay, some change in that. We could have asked all that, right? Now, having said that, what must be the probable diagnosis? We'll make a big guesswork. Doesn't matter if we are wrong. Okay, we are imagining many things. Then he will tell us where the things are. What's your probable diagnosis?
inflammatory bowel disease.
It's an inflammatory bowel disease. Okay. Why not chronic infection? Giardia, amoeba, okay, all chronic inflammation, intestine. Give a thought, doesn't matter. See, I put up a question only for you to think. You are right. But justify that. Why not chronic amoeba?
Can still be there, but there will be history of weight loss or loss of appetite, period of non well-being.
So Giardia is really a large, whitish, greyish, very foul-smelling stool, and chronic amoebiasis also is some change in the stool pattern. Okay, but inflammatory bowel disease could have even constipation, even diarrhea. Okay, so you could have a mix of all that. So possibly that.
See, when we have chronic GI infections, isolated pain for the first 2 months is not a possibility. You must have a local symptom of increased frequency of motions or whatever to call it a chronic gastrointestinal infection.
Okay, and an inflammatory bowel right from duodenum right lower down, and it's patchy. So maybe starting in some small segment, gradually worsening, and now has come to even give you loose stool vomit. Let's see the rest of the symptoms.
The patient was apparently normal 3 months back. Then she developed abdominal pain, which is episodic in nature, periumbilical in location, cramping type, associated with nausea, no relation with food intake, no history of night awakening. Pain was mild to moderate in intensity, which subsides on its own after 1 to 2 hours. No relief after passing stools. No history of alternate stool, loose stools and constipation since 1 month, and we will have episodes of loose stools that last for 1 to 2 days per week, which is 2 to 6 episodes per day, semi-solid, foul smelling, not associated with any blood or worms. History of alternate constipation with abdo-distension, with history of feeling incomplete defecation, and she spends 15 to 20 minutes in washroom. And there's also history of one episode of blood in stools 2 days back, which is fresh, small in quantity, associated with pain during defecation. And fever since 2 days, associated with chills, moderate in intensity, intermittent in nature, subsides with medication. Child is active in interfebrile period. Negative history, no history of weight loss, loss of appetite, no history of vomiting or abdodistension, no history of cox contact, no history of outside food consumption, no history of night awakenings, no history of rash, bony pain, no history of similar complaints in siblings or family members, no history of similar complaints in the past. Past history, no significant past history. Antenatal history is also normal, registered pregnancy, no GDM, PIH or thyroid abnormalities. Birth history, full term, normal vaginal delivery, cried immediately after birth, no admission to an ICU. Immunization, partial immunized till 1.5 years. Developmental history, appropriate for age with good scholastic performance, studies in 4th standard. Dietary history, she is actually deficient in calorie and protein for expected weight also and median weight also, which roughly comes up to 800 kilocalories and proteins of 25 grams. Family history, there is no similar complaints in siblings, and siblings height and weight is also normal. On examination,
Before that, could it be intestinal tuberculosis, alternate constipation and diarrhea? Okay, Nelson writes that. Typical, not IBD, intestinal TB.
No loss of weight and no long-term fever.
There is a poor nutritional intake. Okay, so he must have gone down.
no, matlab there is no history of weight loss per se. There is a history of adequate weight gain.
Fine, but IBD also should have a loss of degree involved. Okay, so why not intestinal TB?
There is no history of contact either.
Who doesn't have contact? All of us have contact. Okay, known contact or unknown contact. 10-year-old, so goes everywhere.
Appetite
Okay,
is good.
so contact.
Appetite is good.
Appetite is good.
Inflammatory bowel. See, we are looking at a chronic intestinal disease. Every chronic disease should have a loss of appetite, loss of weight, etc. Okay. So it's not there is against everything, no. So there is a question. But when I say, Shiv, when somebody asks me now, sir, how are you? I said, I'm all right. I may not be all right. I say, who are you to ask me that? I'm all right. Don't ask me anymore. So, how is your appetite? All right. The point is, every chronic disease has likely to be loss of appetite. Okay. Exceptions are there. Can a chronic disease have an increased appetite?
Can any disease have an increased appetite? Huh? Okay, worm infestation. That's, of course, type 1 diabetes.
So diabetes, hyperthyroidism, okay. Okay, so forget that. So now tell me, why not intestinal TB?
We can't rule out both disease usually mimic clinically and
therefore, when the books write it is alternate constipation and diarrhea, it's not that one day constipation, another day diarrhea, okay, but it's a worsening constipation and then sometimes an overflow which is called diarrhea. That is alternate diarrhea and not alternate day diarrhea constipation. And why chronic intestinal TB presents with constipation, not diarrhea. At the end of the story, there is some over accumulation, leaking, they call it diarrhea. That's why the book says diarrhea. And why is intestinal TB causing constipation when every other intestinal inflammatory disease causes diarrhea?
Stricture formation.
Stricture formation.
And therefore, The intestinal TB, the anatomy is intestine, but the microanatomy is submucosa, not mucosa. When mucosa is involved, you have diarrhea. When submucosa is involved, you have a constriction because of healing, and a typical intestinal TB comes with a repeated subacute intestinal obstruction, in which there is also occasional low stools. So less likely in the child. You are right when you said you must rule it out. Yes, both look very similar, and both look similar to endoscopist, and sometimes both look similar to histopathologist. And I recall children who looks like an IBD, but the test say, no, it's a typical TB. Then you start anti-TB treatment with steroids, he gets better. You call up steroids, he comes with a vengeance. They repeat endoscopy, now they say it's an inflammatory bowel disease. So both mimic each other, you are right, we need to investigate, but small differences exist, right?
On examination, conscious, oriented, active, heart rate is 90 beats per minute, respiratory rate is 26 beats per minute, SpO2 is 100, CRT is less than 3 seconds, peripheral pulse is well felt, extremity is warm, BP is 96/60, pallor is present. Anthropometry, height is 117 centimeters, which is less than 3 standard deviations. Weight is 16.4 kgs, which is also less than 3 standard deviations. BMI also less than 3 standard deviations. Impression is severe thin with stunting. Head to toe examination, head is in normal shape and size, no facial dysmorphism, no cheilitis, no features suggestive of vitamin or mineral deficiency. Trunk normal, genitalia normal, limbs and digits also normal.
Come to positive findings.
Parabdomen distended with prominent veins and umbilicus transversely stretched and slightly displaced downwards.
Child is here?
Yes.
Call him. Go on.
Palpation, non-tender, liver just palpable, spleen not palpable, no abdominal wall edema. Percussion tympanic all over abdomen. On auscultation, bowel sounds present.
I think you look at the nutritional status, growth, etc., which is so poor. What have we learned? When you ask the parents, खाना खाता है बराबर? हाँ, खाना खाता है. We need to get into more detail. I'm sure this child is not eating enough, okay, or has been eating only small amount over a long time. Therefore, they say that appetite is all right, right?
Come quickly, 2 people just check the abdominal findings. Come, Shweta. Someone else? Manas, come.
Looks comfortable, right? And we are talking about chronically sick child. Inflammatory bowel disease, chronic, okay, all that. Something is wrong. So already treated, okay, and treated possibly with steroids, so quick, feeling good, okay. Otherwise,
Abdomen is slightly distended on inspection. Umbilicus looks okay. It is
दर्द है बेटा, दर्द है नहीं ना, थोड़ा दर्द है, बता देना, हाँ, दर्द है तो, okay.
on superficial palpation there is no any warmth or pain or tenderness. On There is no organomegaly, but abdominal feel is tumid. And no visible veins over the. Tympanic sound.
Fine.
There is a slightly distended abdomen with tumid look, so possibly intestinal wall edema with no organomegaly or no ascites.
बस ले जाइए. Thank you. You said tumid abdomen and sometimes you said doughy abdomen, right? What is tumid and what is doughy? I'm sure most of us have never felt the dough, but called doughy abdomen. Okay.
Tumid is little gaseous.
So what is tumid abdomen?
Not so soft, gaseous feel of the abdomen.
And doughy?
Doughy is unequal, like, can't describe.
So now imagine, suppose you have to feel dough. What will you feel?
Springing back.
Doesn't spring back, and there is a little resistance to the feel.
Some resistance and seems to be dipping and coming back. That is doughy. That's what you would do, feel a doughy, right? Yes.
So by examination, what have you confirmed? Is the abdomen normal? No. Where is the anatomy of the disease? Intestine. So examine is confirmed that it's an intestinal disease. Now what is the possible diagnosis? Growth, you know, you've seen the growth. So is this a disease of 3-month duration? So now get deeper into the height and weight. What was the height? 117.
117, which was less than 3 standard deviation.
Huh?
Less than 3
Yeah,
standard
less than
deviation.
3 is fine. We've discussed this earlier also. Less than 3 doesn't tell you whether it's -6 standard deviations or -8 or just -3, right? So 117 is what height age? 7 years old. Very good. And weight was 16.
16.4.
That is what height age? 4-5-year-old. So a 10-year-old girl whose height age is 7 and whose weight age is 4 to 5 years. So now this is definitely chronic and this is not a 3-month story as the symptoms.
And in fact, when the height is at 7 years, the problem could have started even earlier than 3 months, though it could have been a genetically short stature, okay, or a constitutionally short, so we won't know that. But certainly it's a chronic disorder, and the disorder which starts in an intestine, but in a local area in the intestine, which seems to be spreading and now has spread enough to cause even loose stools and further even causing fever, and therefore a slowly progressive chronic intestinal inflammatory disorder. Okay. And therefore between IBD and TB plus minus loose stools, no much constipation, though there is some history of constipation, etc. So both will look alike, and you would say that so which test will differentiate between the two? Biopsy, yes. And I already told you that most of the tests also look similar. So for a clinician, which simple test could possibly differentiate the two? Again, not confirmatory, but reasonably good. In other words, I am asking, what simple tests suggest a chronic non-infective inflammation vis-a-vis infected inflammation? Okay, we are discussing between the two. Which tests might give you a reasonable idea about a chronic non-infective inflammation spread over, okay, like a Crohn's, as against an intestinal TB? And the answer is low serum albumin and a high platelet count. Okay, if you get that, now of course high platelet count is even iron deficiency anemia, all that. All those things are there. And this happens very early in the course of IBD, that you are losing really protein there because of local inflammation. And it's a spreading inflammation as against an intestinal TB which is not spreading. And to that extent, low albumin and high platelet, often high WBC count, leukocytosis, all that would have favored an IBD against a TB. But all this is yes, no. So possibly you will have to do all those tests, and including a biopsy, including a molecular test on a biopsy, bacteriological test on a biopsy, all that, right?
Sir, impression, 10-year-old girl with history of alternating episodes of loose stools and constipation, with gross calorie and protein deficit, with normal birth and developmental history, and severe thin and stunted by anthro, is a case of maybe abdominal tuberculosis, or maybe a celiac disease, or a irritable bowel syndrome.
He does not talk of inflammatory bowel disease. So I think we must give him a credit and still try to understand which one of them are right, or you are right, IBD. He's not bringing IBD at all. He's saying abdominal TB first, maybe. We have discussed that. Can it be celiac?
It usually presents with not only abdominal pain but malabsorption features and anemia, short stature, steatorrhea. This.
Celiac is also an inflammatory bowel disease, but the trigger is known. It is also known that you don't have to start taking wheat or maize and suddenly start inflammation. You could even develop over years, okay. But blood is unlikely, okay. And to that extent, vague symptoms, yes, one could consider that. But celiac goes less on lower down than a typical inflammatory bowel, okay, Crohn's. But both are immune mediated. One, the trigger is known, so you can stop that trigger and you can improve. Diet is the treatment. Here the diet is not treatment, but you know that even IBD, people try different diets hoping that something might work. So celiac less likely, okay. But if there was a doubt after endoscopy, you would certainly look at the specific test for celiac. What about irritable bowel? Who is getting irritated and who is irritating the bowel? What is irritable bowel syndrome?
Stress-induced symptoms of the bowel.
How does the clinician pick up irritable bowel?
More during exam time or stressing events in the home.
What would be the growth status of the patient?
Normal.
Normal.
You have a chronic symptoms simulating, but no growth failure, appetite is good, weight is good, okay. And then you say there must be some stress, anxiety, whatever, and therefore irritable bowel is not the answer. Celiac less likely, abdominal tuberculosis second on card, inflammatory bowel like Crohn's first on card, but all look alike. And therefore today medicine is so complicated that every disease has a wide spectrum, and we go only by the commonness, and in a commonness 1 to 3 but rule out every one of these three, right? That would be an answer, right?
You have any tests?
Yes, sir.
Just tell us the important ones.
In CBC, HP was 7.5 and total count was 5,800. Platelets were normal and CRP is 102. Stool occult blood was positive and serum iron study suggestive of microcytic hyperchromic picture.
Total count is not even slightly low, but neutro-predominant. Okay, tells you that that's more like an inflammatory bowel, right?
Stool occult blood is positive, sir.
Yeah. And TTG is not yet come.
Celiac workup sent, sir, yet to be traced.
Okay. Fine. So right now how are you treating her?
Sir, we are just waiting for celiac workup. After that, she's planned for scopy.
Okay.
Biopsy.
Okay.
I think we need to summarize that. Okay. I think today we had two cases. The first one was a simple nephrotic syndrome. Okay. But we discussed something unusual in that child. First unusual was a fever for 2 days, and that triggered off everything. So we discussed many theoretical possibilities of such an event, and we said that in an apparently healthy child who gets a mild fever and gets suddenly an edema, it is likely to be some complication of that infection, or it is triggered a silent disease underneath which suddenly surfaced. And we discussed about a possible dengue, which is a classical example of such thing, and we ruled out all that because the child was comfortable, happy, etc. And therefore we zeroed down that it was a nephrotic syndrome, but a little difference in terms of fever and then triggered. So we also guessed that he could have had a nephrotic syndrome even earlier, not well treated, maybe partially suppressed, and now the fever has triggered it. And yes, he had some past story of irregular treatment, etc., and that became simple. So this was a straightforward nephrotic syndrome, but we looked at many other issues which were not very classical, and on examination we could also get to guess whether she is being treated, and also if treated, how long she must have been treated. And we discussed that as the steroid treatment starts, every week you see some effects and then you see some side effects. And we saw in that child the peripheral edema was almost disappearing, but her cheeks were getting bloated up. So we said, no, this is the steroid effect, and we would have checked any other evidence of a steroid side effects. And we discussed about the euphoria, okay, then hypertension, a posterior subcapsular cataract and myopathy, and we said we will look at all that, and in an examination such a child you could give a final diagnosis, say that this is a nephrotic syndrome which has relapsed, and I can see that he must have been on steroids full dose for last 3 weeks. You can guess that also, and that is the beauty. The second case was also very interesting, and we did a different exercise. Without knowing much history, we started asking him, and we came almost to a diagnosis of inflammatory bowel disease, and then we said very close is intestinal TB. We discussed the pros and cons, and then the celiac is one of the inflammatory bowel disease, which is a known trigger. That's the difference, and one could even consider to rule out. And therefore, both these cases were interesting, not uncommon, rather straightforward, but we made a lot of discussion on such straightforward patients and analyzed multiple issues. There was a ballotable kidney, so we discussed what is ballotable kidney. So when we discuss together, it becomes very interesting. Yes, the diagnosis in both the cases were reasonably easy, but the discussion could go on around that, and I think that's the beauty of clinical medicine. Well, I think both the presenters did a good job, and I think majority of you interacted well, and we are very happy about today's discussion in general, right? Thank you.
So we end this class here today and we meet once again next Thursday at 6 p.m. Thank you to all our online viewers. Thank you to online faculty. And we thank Aristo Pharma for their educational grant, which helps us to live webcast these classes. See you again next Thursday. Thank you.
These two people came from SRCC. I almost threatened them.